Hello, 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 hello. Hi. Hi, Yvonne. Thanks for joining. Thank you, everyone. I'm just trying to fix my cameras over here so that we will be able to start. Hi, Amayabwa. Hi, Salifu. My name is JustAbbyRN, and I am going to be with you guys today. I hope everyone is doing great. Let's wait. Let's give ourselves like maybe 2-3 minutes, and then we'll get on to our cirrhosis education. So today, all that we're doing is cirrhosis. Cirrhosis, everything, all that you need to know about cirrhosis will be talked here. So thank you for joining me. And I am glad that we get to do this today. My name is Abby, just Abby RN. I'm a nurse in the state of Ohio. I'm a nurse administrator. I work as a nurse administrator. I'm also a clinical instructor, and I also teach. I teach lab and clinicals in a university. Second year students, and I also teach final year students. So you're welcome to my channel. I have the passion to just teach. I have the passion to teach and help people through their nursing career path. So if you're with me, we are live on YouTube and we are also live on TikTok. So bear with me if you ever see me moving eyes and looking at a different screen. I'm on YouTube over there and I'm on TikTok over here. So thank you for joining me. I really, really appreciate you guys for coming in. Please share, and invite someone else. Amayabwa, I'm so glad you're here. And all Nanama, Yvonne, everyone else who is here, I'm really Salifu. I really appreciate you being here. So let's give us a little bit of time, and kindly share the videos. We're on YouTube. If the person cannot be on TikTok, or you know someone who's not on TikTok, they can join us on YouTube. It's the same name, Just Abby RN. The same name. They can join us on YouTube. Thank you. The last time I tried to play music, guess what happened to me? They copyrighted me. So I am just going to try and play just a little bit and talk through it. But you're welcome to my channel. And today we are talking all about cirrhosis. I have my notes right in front of me, and it's just going to be about cirrhosis. Thank you, the YouTubers that started coming in. Thank you so much. Thank you so much for those of you watching me on YouTube. Please share. Yvonne, thank you for sharing. Kindly share and invite your loved ones. This might be useful information for you, for your loved one. Just a general information. This is something that we all need to know. This is something that we all need to know. So share and invite a friend to join us. This information needs to go out to a lot of people. It needs to go out to a lot of people. So invite them and let them come on and let's learn. Let's learn. So today we are going to do cirrhosis, like I said, and we're also going to do something. I have dedicated every skill. Each live stream, we are going to do a skill. And so today we are going to learn how to put on gloves, how to put on surgical sterile gloves. And so Make sure you stay to the end. We are going to talk about some NCLEX questions for those of you who have interest in writing NCLEX. Thank you. Please, please, please share and let someone come on. You never know what they're going to get about it. Cirrhosis is something that we see a lot. It's more rampant than you would think it is. And so it is very important that if you're not a nurse, you're not going to nursing school, you don't have any aspiration in the medical field, it is something that will be vital for you to know. So invite someone. Nurse Chi, thank you for joining. Invite someone to join. Nisha, thank you for joining. Cirrhosis is something that we all need to know about. We are going to learn about cirrhosis. So let's do this 1 minute, and let me reset this. Let me reset my screens here, my big screen here, and then we will go on. But let's listen to King Polita, okay? All right. Thank you for staying tuned and still being with me. Please share and let someone come on. I don't want to waste too much of your time because time is money. So let's share. Please let me know where you're watching me from also. And this is interactive. I just took a run. So I'm struggling to catch my breath. But this is going to be interactive. Alvin, Texas. Yay, Katrina. Welcome. Let me see. The YouTubers, please don't be silent. Let me hear from you also. Okay? Babes, you just graduated with your RN. Watching you from Texas. Yay! Congratulations, babes. Yes, congratulations, congratulations. Who else? Where are you watching me from? Those watching from Ghana, please represent where you're watching from, okay? Yes, please represent where you're watching from. If you're watching from Ghana, let us know which part of Ghana you are. But I will not take too much of your time. It's 10 minutes after 2 o'clock, and let's do this, okay? So, like I said, Stafford, Virginia, Portia. Well, welcome and thank you. I am in Ohio. So I'm in Ohio. I'm in a town called Marysville, Ohio. That is about 20 minutes to Columbus. Yvonne is from Kumasi. Yay! Ellen Amiao, watching from Denver, Colorado. Thank you, Ellen. Thank you, thank you, thank you, thank you. Yes. So I'm in Ohio, guys. Yes, I'm in Ohio. But oh, nice, nice, nice. But if you're new here and you don't know me and you happen to just chance upon this girl talking on TikTok, my name is Abby. Abby, I go by JustAbbyRN, and I'm a nurse here in Ohio. I've been a nurse since 2018 when I graduated nursing school. I have a master's in nursing leadership and administration, and I work as a nurse administrator, as a patient educator for diabetes and heart failure. I also am a clinical and lab instructor for 2 colleges, which I teach 2 first year and second year students in lab and clinical setting, and I also teach final year students in another college. So welcome to my life. I'm in Ohio too, Still, Ohio. Yes, I've heard about Still, Ohio. Um, so is it Stowe? Yeah, and Iron as well. Yeah, I think I've heard about. I've heard that Stowe. Yeah, I think. Yeah. So welcome to my channel, and this channel is just is for us to learn and better ourselves as nurses. If you're someone writing NCLEX, about to write NCLEX, this is good information. I have a passion to teach and inspire. Teach and inspire. Look at that. Well, my YouTube screen is different. So teach and inspire. I have that passion because as a new grad nurse, I did get opportunity to have people help me. And I also thought that how best can I give back to the people who invested their time into my career than to teach. And the best way also to learn is to teach. So that is what inspires me into teaching, and that is what inspires me to helping others, because we all need that somebody to help understand things better, get clarity. And I feel like I can do that. And this is what I want to do in my career. So I'm doing that. I'm also a clinical, I also do bedside at the moment. And so I am a travel nurse that does bedside nursing far in Cleveland. So if you're watching me from Cleveland, I do come to Cleveland every week to do my travel assignments. But thank you so much. So let's talk about cirrhosis. There are a lot of liver diseases. And they gradually start off with just little bit of symptoms and stuff that can affect you as a person. But today we are dedicating. I recommend Saunders and Ewald. Yes. But today, what we are going to talk about is cirrhosis. We are talking about cirrhosis, the disease process, and after this live, you're going to be very familiar with what cirrhosis is and the clinical features of cirrhosis. You're going to know about symptoms, and as a nurse or as someone with cirrhosis, how you're going to manage your disease, or how you're going to manage a patient who comes in with cirrhosis. I have a story to tell about this cirrhosis. So when I get to that point, I'll tell you guys all about it. And that is how nursing is, and we keep learning. So I'll share with you about my story on cirrhosis. But so what is cirrhosis? Like I said, it's a liver disease, and it's the scarring of the liver tissue. It is an end stage disease, which means it's permanent. It is not curable. So what we are doing to cirrhosis is we are managing it. We are managing its symptoms, but the liver is scarred for life. You're not going back to that healthy tissue that you were born with, or that healthy tissue that you had from the beginning. It is destroyed, and it's a chronic disease. Yes, I would say it's a chronic disease, and it cannot be irreversible. The liver cannot, it cannot be irreversible. So cirrhosis is the scarring of the liver tissue that occurs, this is through inflammation of the liver that causes fibrosis. So when we talk about fibrosis, we are talking about the hardening of the tissue. Hardening of the tissue that causes that nodules. I'm not sure. I don't have the pictures here. But if you look at the picture, my thumbnail, there is a healthy liver tissue, and there is a cirrhosis liver. That is the difference. So you see the nodules, those small, round things on it, that is the inflammation, and it's hard. So the normal tissue, healthy tissue is there, and this has been a layer, a hardening layer on top of it. So basically it's a hardening of the liver, and those nodules that affects the function of the liver. So the noodles on it, the scarring affects the functions of the liver. So I will first talk about some functions that is being affected by it. So when I talk about these functions, we can in a way turn it around and say that these are, but if you still think, I'm sorry, these are the importance of the liver. So first of all is the scarring of the liver, that is the cirrhosis, causes a decrease in bilirubin metabolism. So bilirubin is a byproduct which we have in our red blood cells that breaks down liver enzymes. Okay, so we have our red blood cells that is being broken down, and bilirubin is the byproduct of that. Now, we excrete bilirubin out of our system. When bilirubin stays in our system, that is when is because the liver is not functioning well. It goes through our digestive tract for it to be excreted. Now, when it builds up in the body, it builds up in your bloodstream. That is when you have cirrhosis, because there's a decrease in that metabolism, it just stays on you. Okay, I guess you guys are following me. It's built up in the blood when the liver cannot process the bilirubin anymore. It's a byproduct, so it goes through some kind of process, and that process is compromised when you have that hardening or the scarring of your liver tissue. The second one is it decreases the function of the liver. So when someone has cirrhosis, the synthetic functionality of the liver has been decreased. That means, okay, so the liver decrease, the protein synthesizes with the liver, and so if someone has it, then it means that that function has been decreased, and that will cause coagulation factor. Coagulation factor is what we, if you're a nurse and you've ever given heparin, we use that as a blood thinner. So coagulating is thinning the blood so that it flows well. It flows as it should, so that there are no clots in the system. And the coagulation factor in the body, such as the prothrombin, is created also in the liver, as well as albumin. So the liver it does a lot of things. We've learned just now that it breaks down bilirubin. Now we are also learning that the prothrombin, that is the coagulation factor, goes through the liver as well, and most of the immunoglobulins, those also go through the liver. So the liver is really big for our metabolism. Altered metabolism of hormones, especially estrogen, which we mainly see with males. So if someone has an issue with your liver, as in this case, like you were discussing, cirrhosis, there is some metabolism changes, and it alters especially estrogen. So I'm not sure if you've seen a picture of someone with cirrhosis. I'll try as much as possible to give you a perfect description of someone who has cirrhosis. But let's say you have seen someone with cirrhosis before. Especially with males, have like breasts and stuff because of the disease. It gives you, it increases the production of estrogen in the system. Cirrhosis increases the production of estrogen in the system, because that production is altered, and that is why it's not because you have to have it, but because it has altered the metabolism. Now you are having estrogen, and for a man to have more estrogen, then you start having those features that typically a woman will be the one to have in your system. Okay, so you start having such manifestation. Once we go to the clinical features, I think this will make a lot more sense. But this is just going through the pathophysiology of it and also the importance of it. Okay. Thank you, Nanajo, for following me, and I follow you right back. Yes. Also, the fourth thing that we're going to talk here is altered blood flow through the liver can lead to portal vein hypertension. So you having cirrhosis alters the blood flow through the liver that can lead to portal vein hypertension. And we all know that our portal vein is in our gastric digestive system. That is where our portal vein is. So when we are having the blood flow into our portal vein being compromised in a way, then we're going to have some digestive issues. We are going to have hypertension, and we're also going to have some digestive tract issues. Portal vein hypertension is an elevated pressure in the portal vein system, like I said, in the belly. And the portal vein collects nutrients, that's the rich nutrients from the blood, and goes through the intestines and carries it into the liver. So that's the main function of the portal vein. Now, if the portal vein is compromised, then we know for a fact that we are really not getting what we are supposed to get, and it's not passing through our system. All these nutrients that is supposed to build us is not passing through our system well. Now that we know about some of the functions that cirrhosis affects, let's talk about the risk factors. How can someone have cirrhosis? What leads to you getting cirrhosis? And the first thing is chronic or viral hepatitis. But I saw a mnemonic that I would like to share because I find that helpful for you to remember, especially someone writes it incorrect. Babes, this is for you. Alcohol, hepatitis B, hepatitis C, and diet. We call it the ABC. There are some people that have the AC and the 9H. I think that is very detailed, but the ABCs kind of like puts everything in a nutshell. Alcohol, hepatitis B, hepatitis C, and diet. These are some, in a nutshell, you can put the four causes of cirrhosis into this nutshell. But let's delve a little bit deeper into it. Chronic viral hepatitis B or C is an infection that can really be prevented through vaccination. And this is a cause. If someone has hepatitis B or C, they stand at a risk of having cirrhosis. Okay. Then we have the chronic excessive alcohol use. Yes, I don't know if you've heard this. When someone, I had a doctor say that, oh, if you drink alcohol, something the patient was talking about drinking alcohol before coming in. It's like, listen, alcohol is going to end up hurting your liver. Yes. When we see someone who looks disfigured, like someone who drinks a lot, you can see their mouth, their belly. We'll get to that. That is signs of cirrhosis, and you stand at a risk. You stand at risk into getting that disease. So chronic alcohol use, excessive. It's not the small ones that you've been doing at home. It is, yes, ascites. It is the big ones. It is the big ones that we drink and we booze, and you keep doing it chronically, repeatedly. You keep doing it. It's your lifestyle. Yes, that can cause cirrhosis, because what alcohol does is causes inflammation to the hepatocytes. So alcohol is causing inflammation to all those cells, your liver cells, and that can lead to the scarring of the liver tissue. So these are not drinking alcohol recreationally. This is like drinking, like you've decided that you want to drink and you're drinking. I'll share a story about that too, but I want to get to complications of that. Non-alcoholic fatty liver disease. People who are obese stand at the risk of getting this non-alcoholic fatty liver disease, people who stand at a risk have that tendency of also getting people who are obese, heavy weighted, because of the fat in them. They stand a chance of getting cirrhosis. Okay, so pathophysiology is gone. We've had that. We've had the importance of it. Now let's talk about the another thing, that is the clinical features of cirrhosis. So we were talking about bilirubin earlier on, which we talked about the fact that it was a byproduct of cirrhosis of the liver, and metabolism of that goes through the liver, through the intestines, and then it's supposed to be excreted out. Bilirubin is not something that should stay in our body. When we have an increase in bilirubin level, it is not good for our system. Now, and that is what will cause jaundice. So cirrhosis patients have jaundice. The yellow the yellow skin is from them being jaundice, and that is because of cirrhosis. It's because the bilirubin is now showing on their skin, is depositing on the skin and on the sclera, so their eyes looks yellow. I remember when I was in nursing school, one of my clinicals, I had a patient who was in end stage, like who had liver disease, like she was dying, and she was yellow. She's Caucasian, but she was very yellow. Her sclera was yellow, and by the time our clinical ended, she had passed. Yes, you could see her and you're like, what am I looking at? That was a perfect case of someone with a liver disease, well, with cirrhosis. It's end stage, nothing can be done about it, and she did unfortunately pass. So the skin is yellow, and they also itch a lot because bilirubin that is depositing. Hi, Linash, hi. That bilirubin that is depositing on their skin causes a lot of itching, on their skin, because it just stays in. Now, it also affects circulation. So clinical features, you see them with darkened urine. Their stool also becomes really pale because the bilirubin is in their blood. Hi, Tina. Hi, Ajua. Thank you for following me, Ajua, and thank you so much for following me, Ajua. I'll follow you right back, Ajua Daku. So, because bilirubin is staying in their system, their urine is dark, and also their stool looks pale. It looks pale in color, and it is not being deposited because you're not excreting the bilirubin from their system. They are not excreting it. So there's urine. This is a telltale sign. Their urine is dark, and their stool is very pale. You see their stool, it has this it almost look like ayilo, like chile. That's how chile will say. Yeah, those of you from Ghana, you understand it. It looks like that. Then because it's causing that decrease in protein synthesis, we did talk about the coagulation factors, the PT and the PTT. There is an increase in bruising. For patients like that. They have generalized bruising because of their coagulation deficiency. The blood is not clotting enough. They don't have that clotting factor. So the least thing, they scratch on their skin because they are itching. They keep scratching, and then they keep losing like blood, getting bruises and oozing out like small blood on their skin, and then having those bruises. Okay, and fluid is built up in the abdomen also. And so what we are seeing in ascites, babes, they say that ascites albumin, because of that albumin is also important so that we can maintain that pressure in the blood vessel. Okay, so they get generalized bruising, their fluid builds up in their gastric system, and so you see them with big tummy, and it's they're not pregnant. They sometimes they almost look like they're some few months, like 9 months pregnant, but it's just that fluid that has built up in their guts, and that is because they don't have albumin. They have albumin deficiency. They also build up estrogen. I said that earlier. They build up estrogen. So most of the men, you see them, they have the gynecomastia, that is enlarged breast tissue. So you're like, you're a man, but why is it that they have those features, especially with the breast? You see that, and they lose hair. They lose hair a lot. The men will lose their facial hair because now they're becoming almost like females. So estrogen, they are losing hair. Okay, and they also come in have presents usually for the men with testicular atrophy. Estrogen can also vasodilate the blood cells that will also which will manifest in them, and that is the spider as well as the I don't know if you've seen the palmar erythema, where the palm of their hands is red. The palm of the hand, like they have redness. Sometimes it will just like gather in one spot, and that is palmar erythema. We talked about the portal vein hypertension, and portal vein hypertension can lead to different abnormalities, increase in blood pressure and all that. Oh, Mrs. General, you're late, but better late than never. We are talking about cirrhosis, like you know about, but we did talk about the pathophysiology of it, and you're not too late. I will try and put some things in, and you still stay on top of it, so don't worry about it. But welcome, and welcome to everyone else who's been in Nobuama. Mrs. General, thank you for coming. So the portal vein is receiving blood from the veins of the esophagus to the stomach. We talked about how it goes through the digestive tract system. Okay, so and it goes through the portal vein. Portal vein does that. That is what receive blood from the veins through the esophagus to the stomach, as well as the spleen and the intestine. Now, when the blood flow is now really poor, it back ups on those organs, and that can lead to esophageal varices and stomach varices, and that can be very life-threatening, causing a lot of bleeding. It will cause GI bleed. So sometimes someone with cirrhosis will come in with some GI bleed, which can be upper or lower, and in most cases, when it's upper, it's because they have some esophageal varices that needs to be taken care of. And because they are making a lot of albumin, and they have albumin deficiency, and their coagulation factor is not as there as it should, they don't clot enough, so it's easy for them to bleed. And another clinical feature or something that can a symptom is the splenomegaly that can develop when the blood backs back into the spleen. So blood is not able to go, like I said, with the portal vein hypertension. So now it's backing back into the spleen. When it backs back into the spleen, it can cause that, and it will enlarge the spleen. So the spleen will get bigger and increase, which will distract the white blood cells, and in some cases, red blood cells will also be destroyed. So, yes. So when you see patients with that, Sometimes their hemoglobin levels are low, their platelets are also low. It can cause a lot of complication. So all these clinical features we are seeing, but what actually goes on in their system, okay? Complications of cirrhosis, hepatic encephalopathy, hepatic encephalopathy. They are very, they get to be confused, but that is because um, the liver is unable to, ammonia is being built up in the system. We all know, or if you don't know, ammonia causes, when you have too much ammonia in your system, you tend to be very confused because it's building up. And we'll talk about medication that helps with that. But when ammonia builds up into the system, it deposits all these things in, and because you are not letting it go, remember we are not excreting, so that causes that build up, and we tend to see patients with encephalopathy, hepatic encephalopathy, in their system, okay, because we have ammonia in the system. It's being circulated in the brain, which can cause cerebral edema as well as cerebral hypertension. Then ascites is the common manifestation or clinical feature of cirrhosis, because I think it's because the stomach is big. It's just that you see it. Encephalopathy, we will have a lot of things that fights it. So sometimes a patient will be in hepatic encephalopathy, but if they already have dementia, you're kind of like conflicted on what is causing the confusion, what is causing the agitation and all that. But ascites, we all see the enlarged abdomen, and you know that their diaphragm, then we know that they have cirrhosis. If they are not pregnant, if you find a male that you know drinks a lot and their abdomen is big, they have some kind of liver disease. It might not be end stage, but they are beginning to manifest such symptoms of a person with cirrhosis, okay? Then we also see them, sometimes they have difficulty breathing, shortness of breath, and it's because their gut is big, their abdomen is getting bigger, and once it starts, you have that fluid build up, it's pushing on their diaphragm, it's pushing on their lungs. So you see them with when you listen to them, they are very drunk because they have atelectasis. In some cases they might end up with pneumonia. They might end up with pneumonia because of all that fluid that is being built up for. Yes, yes, they will need paracentesis. Babe, hey babes, let's inquire that you're going to write. You are like going to kill it. Ascites is very uncomfortable. If you have a patient with ascites, they usually will not sleep in bed. They are always sitting up, because when they lay down, they will tell you that I feel like I'm drowning. They're basically drowning. That is how it feels like, because of that fluid that is built up in them. They always want to sit, and you find them sitting and then sleeping. They don't prefer to lay in bed. They also sometimes will require oxygen at night so that they will have better breathing. Giving them breathing treatments and all that is good, but the best thing is getting that fluid out. They also one of the complications is a spontaneous bacterial peritonitis. The liver is very important when it comes to synthesizing immunoglobulins. Yeah, so immunoglobulins, and these are the antibodies we use to fight infection. And if the liver is not able to synthesize that, you are prone to being infected. you're prone to having infections, having bacterial infections, because we all know that bacteria love to grow. They love to stay in comfortable places. And this is the case that you have been immunocompromised. And so they will just grow and proliferate. They'll just grow and proliferate and just keep growing. So we are watching out for all that. When you have, and also gastrointestinal bleeding, it can occur from the rupture, like I said, with the esophageal varices. This can be life-threatening. So this is where I'm going to share my story. We one time had a patient who had come into the hospital, was a housewife, and just was having some abdominal pain issue. Came in, got taken care of, went home. But when she came in day 2 into day 3, she started getting very confused. And it was more like someone who was withdrawing from something. Husband denied that the wife was into any medication and anything that will make the patient be going crazy. He was blaming us for giving her narcotics, and that can also present that. So she said the pain medication is making this patient confused and we are not treating her right and all that. But we did a CWA on the patient, and we realized that she was calling for the CWA. She had the trembling, like she had the tremors, she had a headache. What else did we search for? She had the hallucination. She was confused. She had verbal hallucination. She was seeing people. She was seeing cats. She was saying a whole lot of things. So we started giving her Ativan. Anytime we called her for the CIWA. So CIWA is CIWA, and that is a shortened what does it stand for? So that is a shortened form for Clinical Institute of Withdrawal Assessment. Clinical Institute for Withdrawal Assessment. So we kept doing that CIWA on her and medicating her and getting her comfortable, because it's a score, and when they score below a certain number, you give them a dose, like some dose of Ativan. When they score above, some of them, they get something more to it. Every hospital has their own protocol, but we score them, like we assess them for every 4 hours. In this case, it can go to a day, depending on how the patient is feeling. So when she started scoring for the CIWA, we were talking about it. Husband said, no, it's pain medication. We stopped all the pain medication. Then we told the husband, the doctors told the husband that your wife drinks alcohol. Said, no, we are occasional drinkers. We just drink it when we go out. She doesn't. And the doctors tried to tell the husband that your wife is drinking more alcohol than you know of. He did not believe us. And then being upset with everything, treated the patient went home. In a space of 8 months, that woman passed in our hospital. And what had happened was, because of the coagulation factor, she now became a frequent person in here needing paracentesis, which I'll talk about. But because now it has opened for all these things, portal vein hypertension, she was jaundice. She started clinically showing like someone who had cirrhosis. She got a good diagnosis. She later on got diagnosed with pancreatitis and cirrhosis. Okay, when that happened, she started deteriorating. She came in skinny, with distended abdomen and all that. She later on one time came in very sick from the ED. They transferred her to the ICU at this point, and what happened? She coded right before she could go into the ICU. And with her code, I have never seen this before, and I've never seen this after her. Whilst we were doing the compression, because when she came in with bleeding. that was the next thing that she came with. And we talked about the coagulation effect. When we were doing the compression, with each compression that you did, like you push on her, because mind you now she's very thin, and so when you push on her, she was on 4 liters of nasal cannula. When you push on her during the cold, blood starts coming out from every orifice of this woman. It was so sad, but she had blood coming out from her ears, her mouth, like everywhere that blood should come out. Her eye, she had blood coming out from. So the husband, upon watching, is like, let's stop, because she was a full cold, so we needed to resuscitate her. But that was the effects of alcohol. And we see that a lot, and we see family members deny that our person drinks. We see that a lot with moms who stay at home. Children go to school and they drink, and husband doesn't know because husband is at work. So sometimes it's very difficult for them to admit that they are doing that, shame and everything. But most importantly, when you have a female stay-at-home mom, it's not a stereotype. A stay-at-home mom come in with all the signs and starts getting what do you call it? Starts scoring for CIRRHA, that is the Clinical Institute of Withdrawal for Alcohol Revision. Once you start doing that, you start looking at those and they start scoring higher, they might have been drinking without anybody's knowledge. So that is my story to share. Cirrhosis, it's deadly. It's a disease that you don't want to have because it messes with everything. And the more people are trying to help you, especially with the coagulation issue with blood thinning, it thins your blood really bad that you will bleed to death. And basically, that is what happened. It was a complication that was caused by her bleeding to death. It was sad that like blood was screaming all over. Like that is all that we could see was blood all over. So please, if you know somebody who drinks, let them know that it's not going to lead them anywhere. It also increases your risk of getting liver cancer. It increases your risk of getting liver cancer, okay? So now we've talked about lab. Let's talk about labs. What are the labs? How are we going to see a person with cirrhosis lab? Their labs are so like remarkable because everything, like the numbers don't look right with cirrhosis. Bilirubin is high. We are talking about the elevations now. Bilirubin is high. Their PT and PTT is high. That's the prothrombin. Yes. ALT, AST, that's the liver enzymes are high because blood doesn't the factors are normally synthesized in the liver, so it's not being synthesized. That is why we are seeing all these increases. Ammonia is high because ammonia is being stored in the system, in the blood. So the serum ammonia will also be elevated. And let's talk about numbers that will go down. So numbers that will increase bilirubin, serum bilirubin will be elevated. Clotting factors such as the PT and PTT will be high. Liver enzymes, ALT, AST will be high. Serum ammonia will also be high. And what are things that will be low? Serum albumin, because we talked about the splenomegaly, will be low. Platelets, we talked about platelets being low, and that can even end up leading them into some hemoglobin counts also being low. When RBCs are destroyed, because we did talk about the fact that it's destroying some cells, the hepatocytes, and that can also cause that. So that will also be low. So as a nurse, what are some of your interventions? We are monitoring for the flapping. So when they come in and they have that hepatic encephalopathy, They also have something that we call it, oh God, I hope I don't massacre this name. It's asterexis. They have asterexis, and that is the flapping of their hand. So yes, yes, the flapping. They have asterexis. Thank you. I'm the one God said I am. Yeah, they have that. So they have that flapping, and we are monitoring for that. It's an indication of a hepatic encephalopathy. They have elevated we have to, as a nurse, you have to make sure you're elevating the head of their bed so that they don't get dyspnea, because with the ascites, that is what is going to happen after that. We administer the diuretics. So we are diuresing them so that they can get fluids off. Sometimes they tend to have those electrolytes imbalances, so that you have to be careful with what you're diuresing them with. If someone comes in with big belly and their potassium is low, you're giving them a potassium sparing diuretic, because you don't want them to drop so low. Potassium sparing diuretic, that is in the form of no, if their potassium is low, you are giving them a loop diuretic. If their potassium is low, you're giving them a loop diuretic, that is the furosemide Lasix, to get fluids off. If their potassium is high, we are sparing it, and so we're giving them potassium sparing diuretic, that is the spironolactone. Yes, yes, we are holding. Yes, thank you. I had to correct myself. That potassium stuff, sometimes it just, when you're talking, like your brain is behind, your mouth is going faster. But yeah, so Lasix, when we give Lasix when potassium is, we're giving them Lasix when their potassium is high. And so when we lose those, it will not. Okay, I'm confusing myself. Potassium sparing is the spironolactone. So we are sparing the potassium. If their potassium is high, we are giving them Lasix. When their potassium is low, we are giving them spironolactone. Yeah, babes. If the potassium is high, we are giving them Lasix, because that is, will go with that. When we are sparing their potassium, that is when we're giving them spironolactone. Yes. So potassium high, you're giving them Lasix. Potassium low, you are not taking any more potassium from their system, and so you're giving them spironolactone. Now, how do we manage the ascites? We are managing ascites by taking them down for paracentesis. And as a bedside nurse, when you have a patient who is going for paracentesis, we are looking into, okay, first, the paracentesis site. We have to make sure that the site is clean and there is no no dirt, or we are covering it up. Some patients who have cirrhosis for a long time prefer that we put a gauze and tag them on the site. And as a nurse, you are always assessing, beginning of your shift, you are assessing that site. Okay. The other thing that you're looking for is, because they are depleting all these fluids is coming out of this patient, they might have that portal-vein, they might be hypertensive, and we do not want them to go into a hypotensive state. So we are monitoring their blood pressure closely monitoring their blood pressure before paracentesis and after, especially after. Because when they are built up with the fluids, their blood pressure can go up and they will be hypertensive. But the moment they take all this, they dry them out with that, and coupled with having been on Lasix or whatever, Lasix or spironolactone, you are monitoring them that their blood pressure will not go. They stand a chance of being hypotensive. So we are monitoring that closely. And if they do go low, instead of the physicians ordering fluids, like how we treat hypertension, they will end up not treating, they don't treat it that way. What they do is to give them albumin, because we know that they have albumin deficiency, which causes portal vein hypertension. And so when you're taking all that, they need that they need albumin back, because they have the albumin deficiency. Like we talked about, the lab albumin levels are low, so we increase it, and then you start seeing an increase in their blood pressure. Okay, all right. So daily weight, we are checking their weight daily. This is how we know how their colloids. Yes, we'll come to that. Yeah, colloids, as in giving them that albumin. But albumin is a colloid. Hey babes, this NCLEX, let me know how you do. The moment you're done writing your NCLEX, please message me, because I think that you're good with your NCLEX. But yeah, then I was talking about daily weight. That is how we know that their fluid buildup, how severe it is. Someone will go drain out 3 liters and then come back, and then within 2 days they've increased in weight, or the belly is full, and then they're just filling up so fast. And they fill up so fast that it will surprise you that you have a patient who just came back, and the next 2 days, for some reason, the patient is with you due to presets or anything, and they come back, and you come back to work, and they're still there, and paracentesis is scheduled for tomorrow. They just had one. Yes, because the cirrhosis is so bad. Okay, so we are measuring their abdominal gait also to get that measurement, so when it's enlarging, you can see firsthand that the abdomen is filling right back up. We are implementing fluid restriction, sodium especially, because they are retaining urine, they are retaining fluids. So we are making sure that we are implementing sodium, a good sodium, heart healthy diet. And that brings me to my second story that I said I was going to share. When I was a new grad nurse, I had a patient with cirrhosis. Had ascites, did not come to the hospital. That they came in for a different thing. Around 3 o'clock, I realized that the patient was not urinating, low urine output, and so I was concerned about it. But the patient, while we were taking the patient to the bathroom, but the patient said, "Oh no, I peed before I went to sleep." And usually it's a surgical unit, so when the MPs come in at 9 o'clock, they don't want to see occurrence, especially with someone we are monitoring their fluid. They don't want to see occurrences. They want to see you measuring their urine. And so I got concerned. I was like, I need this man, because we had charted occurrences for a while. So I said, I need this man to pee, so that I can say for a fact that, oh, the last time he peed, we did occurrences for a while, but the last time he peed, he had 400 out, to bail myself from the MPs, because they will be so upset with you. I went in, I said, please, let's do it. And we didn't believe that he was really peeing like he said. And so I told the girl that my PSA that let's do a bladder scan. We did a bladder scan, and we got like, it read that greater than 1,000. I was like, oh my God, greater than 1,000. So he's having fluid retention. I did not think about anything, urine retention. I did not think about anything. Immediately called the doctor, wanting to tell them that the patient has, we need to straight cut the patient. And the doctor was a very good person, like good friend, someone I know. And he was like, Abby, calm down. Your patient doesn't have urinary retention. I said, it says, the bladder scan says over 1,000. Said, yes. What is happening right now is your patient has cirrhosis, and so their abdomen, it's filled with fluids. So you are not getting a true representation of their urine output. So believe them when they say that they are urinating, because for real they are. I said, no, you don't know what I'm talking about. He said, like he's built up. That's when he said, yeah, I know what I'm talking about, girl. The patient is not retaining. If you straight cut him, you're not going to get anything out. So we'll keep monitoring, leave it for day shifts, but I'll put a note in that I asked that the patient should not be straight cut. And yes, for a fact, he knew what he was talking about. He's a friend, so sometimes I play around with him. But he knew what he was talking about. The patient was not retaining. So when you have a patient with that history and the patient is not peeing, or for any reason urinary retention comes into play, please make sure that you're going down below the bladder, and sometimes your fluid counts might not be exactly what is happening because the patient is so much built up there. Also, avoid sedatives. So patients like that, we are avoiding sedatives like opioids and benzodiazepines. And this is because we want to reduce the confusion that the ammonia already in the system is causing. And that will, because we want the bowel system to move and everything. But if we want to increase that motility, then we want the patient to be up and with it so that ammonia will absorb in the gut. Because the more you move, the more absorption happens in your gut. So we want to do that. So we have to avoid sedatives and opioids. We also have to avoid Tylenol. Tylenol is dangerous to the liver. Tylenol is dangerous to the liver, so we are avoiding Tylenol intake, and we are also monitoring for signs of bleeding. Because of the coagulation factor, we have the increase in PT and PTT. We are monitoring them for signs of bleeding. Any signs of bleeding, you are letting someone know about it, because they stand a chance of getting upper GI bleed, and those upper bleeds, how do we see them representing? This is just, by the way, it can be dark brown stool. You can tell that this patient is bleeding. It smells like blood, but for a fact it's black. Tarry black is dark. It means that the bleeding has gone on for a while, or it's in the upper GI esophageal area. Okay. We are also avoiding alcohol. We are talking to them about alcohol use and cessation. How can we help with alcohol cessation? What can we do? We are helping them with the CIRRHOSIS score. We are also, some of them will be on a phenobarb taper. Anything to help them stop the alcohol will also be a good thing. We are watching them for withdrawals, alcohol withdrawals. We did talk about the Clinical Institute of Withdrawal Assessment for Alcoholics. That for alcohol, that is CIRRHOSIS, and we are watching them continuously. We are watching them for signs and symptoms of it. And some of the signs of symptoms of it is patient alert, unoriented. Is patient does patient have tremors? And sometimes the tremors are so settled that you have to put your hand underneath their palm, like you have them stretched like that. And that is the best way for you to see when they stretch like this and they cannot keep it. Or sometimes you have to feel it, and when you feel it, you can feel that it's like just shaking. We are assessing for hallucinations. We are assessing visual and audible. So sometimes some of them will like, I'm hearing stuff. What did you say to me? You could go into a room and it's like, what did you say to me? I didn't say anything, but they are hearing that people are talking to them. They will see cats. They will tell you that I see a cat. I see a cat. The cat is right there. Why is the cat looking at me? We are seeing all that too. So we are watching out for symptoms of so we are watching out for symptoms of alcohol withdrawal. We are also encouraging them to get their hepatitis vaccinations and skincare for the jaundice, yellow looking skin. We are talking to them about how they can improve their itching. Sometimes they give them low dose Benadryl to help with the itching. You often see Benadryl not being in their medication, but the doctor will order it as and when the patient needs it. So they order it as and when the patient needs it. And so we see them getting Benadryl or maybe getting Atarax for it, hydroxyzine, getting some, getting Atarax or Benadryl for it. Sometimes they'll even just give them Claritin for that because of the itchiness when they don't want to go like really harsh on the liver and the kidneys as well. Skincare, they can order calamine lotion. They can order calamine lotion that the patient can put on their skin that will also help with the itching. So paracentesis, only a healthcare provider will be able to put in that order and also do that for them. So that is all I have on the cirrhosis. If you have any question, please write that down. We have some English questions that I want us to discuss. It's a good way of learning. And so let's talk about my first question here. Okay, then the nurse is reviewing the record of a client with cirrhosis and notes that there's a documentation of the presence of asterisis. How should the nurse assess for its presence? So how are you going to assess for a patient who has asterisis? How are you doing that? The first, dorsiflex the foot, measure abdominal girth. B, ask patient to extend their arms or instruct patient to lean forward. The first is dorsiflex the foot, measure abdominal girth, ask patient to extend the arms, instruct patient to lean forward. Let them raise their, you say what? Let them raise their hands. Yes. Extending your hands, raising your hands, that is when we see the asterisk, because remember I said it is the flapping of the fingers. It's the flapping of the fingers. So raising your hand. Good, babes. The nurse is reviewing lab results for a patient with cirrhosis and notes that the ammonia level is elevated. Which diet does the nurse anticipate to be prescribed for this patient? What diet do you anticipate for a patient whose ammonia level is elevated? 1, low protein. 2, high protein. 3, moderate fat. Or 4, high carb. We have low protein, high protein, moderate fat, and high carb. Ellen, are you still on? Yeah. And with elevated ammonia, what are we looking at? Elevated ammonia, low protein, high protein, or moderate fat, or high carb. We anyone has an answer for us? Low protein. Protein provided by diet is transported to the liver by the portal vein, and the liver will break it down. So we are encouraging low protein. The other thing I will say about ammonia is, how do we get rid of ammonia in the system? Remember, we are talking about the fact that it's not being excreted out, so the stool will look pale. So how do we excrete it out? We excrete it out by giving lactulose. Lactulose helps with the excretion of ammonia. Yes, lactulose. And I know people don't like it because they will poop they will poop the ammonia out. Yes, they will poop the ammonia out. And whenever you hear lactulose, you know, if you have a patient who is on lactulose, know that they're going to poop. They are going to poop. During assessment of a patient with obstructive jaundice, the nurse would expect to find clay-colored stool, dark urine and stool, pyrexia and pruritus, elevated urine urobilinogen. What is the answer? Clay-colored stool, dark urine and stool, pyrexia and pruritus. What will be the answer? I'll just go ahead with it. Clay-colored stool, because dark urine is only for, we do see, and that's one, you know, like this question is a very tricky one. It said clay-colored stool. That was an answer. Then the second one is dark urine and stool. We see darkened urine in a patient with cirrhosis. We don't see dark stool. So if you're one that just jumps in and answer the question, you might end up taking dark urine and stool just because they brought in the dark. It is to confuse you so that you don't know what you're talking about. And so, and they said pyrexia and pruritus, but we know that they only have itchiness. Okay, they are jaundiced and they have itchiness, and this patient already has the itchiness, has jaundice, and so we are choosing the clay-colored stool because of the nature of the stool. Okay, then our next one, let's see. A patient with advanced cirrhosis asks why his abdomen is so swollen. The nurse's best response is based on the knowledge that why the abdomen is so swollen. Why the abdomen is so swollen. A, lack of clotting factors promotes the collection of blood in the abdominal cavity. We all know that is not true. The lack of clotting factors does not promote collection of blood in the abdominal. Well, it does promote it, but that is not why the abdomen is swollen. It is not why the abdomen is swollen. Portal hypertension and hypoalbuminemia causes fluid shifts into the peritoneal space. Decreased GI tract movement contributes to gas formation and distension, and bile salts in the blood irritates peritoneal membrane, causing edema and pocketing of the fluid. So we are going with the side B. B is portal hypertension. Yes, babes. Yes. Portal hypertension, hypoalbuminemia causes the fluid shift in the peritoneal space. Ascites is the accumulation of serious fluid in peritoneal cavity. When the portal vein hypertension, with portal hypertension, protein shifts from the blood into the lymph. When the lymph system is unable to carry excess, it leaks through the liver into the peritoneal cavity. So, resulting in the decrease in oncotic pressure. Yes, that is why we need the albumin for, whereby albumin is a colloid. Okay, so we have our stuff. I hope you found this useful, and it will help you remember stuff. I hope I reminded someone. If anything, I hope this was educative enough for you. And please join this. This is going to be a weekly thing that you'll be doing. Next week, I'm still working on the dates, but next week we are going to do this, and I will put forward the time that we are going to do this next week. I'll also put forward the topic for next week. I really appreciate you. So real quick, let's do our skills. Remember, I promised you that we're going to do a skill every time we are on live, and this live is being recording on YouTube, the same name, JustAbbyRN. Just Abby RN on YouTube. This live is being reviewed. So please, Mrs. General, you are late. Go and start from the beginning. And from the beginning, I mean going to YouTube to start from the beginning. Abena Dankwa, thank you for joining. But I have this very useful done review on this topic. Thanks. Well, I hope I gave you all that you need, and I believe this is all that you need to know about your cirrhosis. Yes, Mrs. General, go and watch. And I have my sterile gloves, surgical gloves. This is a size 6.5. I'm usually a 7, but I couldn't find a size 7. And I said, yeah, I couldn't find a size 7. So you have to know your size. Size too big gets in your way. Size too small, too tight that you can't do anything. So know your size and use that appropriately for your gloves. So with this, I will tell you this. I have size 6.5. It's a surgical sterile gloves, and we're going to go on with it. Oh, you're welcome. Now, why did you change your name? I'm the one God said I am. Yes, you are. But I know you with a different name. So you got me confused. It was your profile picture that saved me. All right. So let me bring this down a little bit so that we can see what I'm doing. YouTubers, come down a little bit. Oh, my phone is in the way. I'll see what I can do. There we go. There we go. Yes. All right. So I have to be on here. There we go. So I have my sterile gloves. And let's say yeah, Sarah. Yeah, that's why I said you confused me. I walk into a patient room. Hand washing is very important. So I wash my hands with alcohol or wash it with what do you call it? Alcohol or water. And then this is my glove. So this is a sterile glove, and we are making sure that we're keeping the sterility of it, okay? And this is how it comes in. I open it. It's like this. I open it up and then open it wide open. So that's how it looks like. Soap and water, yes. That's how it looks like. And usually we're using this for what? When we're putting NG in. I like to wear it. I don't know about you. When we are putting in, like we are placing a Foley, we are sometimes some people even wear it for straight cutting and all that. We want a sterile field. So we have this like that, okay? And it's like the edges of it is folded. And so we are going to fold it out. But because it's a sterile fold, we are not just taking it out and wearing it. We have to be cautious so that we can keep that sterile field. We're keeping it, okay? All right. So this fold goes that way. And then make sure that it stays, because we don't want it going back and flipping like it just did. So sometimes when I was in nursing school, they taught me to fold and kind of like pinch it, and then it will stay. I hope it does. Then we come here and also fold and pinch it. So when you fold and pinch it down, it stays. Then we have the sides here that you can hold. You can see it's folded on the sides here too. So we do the same thing, and voila. And this side, me nursing school, I'm only giving you my nursing school and how I do it in practice. So I teach this. You hold it tight like that. You hold it like tighter, and then kind of like you're stretching it, and then you leave it like that. because you saw how that one flip back. It can this can flip together too. So you hold it like this and kind of like straighten it, and it stays like that. Okay. So now with the clean hands, we already washed our hands and we already did what we're supposed to do. I'm going to put on this one first. So this one, this size do not need to stay sterile. We don't need that to stay sterile. So with this one, I can pick it however I want. This is my sterile field. I don't want anything coming here. So with this one, I can just pick it like that because this is the inside. It is the inside. And what I am going to do is to put my hand in gently, 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 gently. And then I have it on. Gently, and then I have it on. I always teach my students that whatever you do with this, if it doesn't, you don't get your fingers to go in, don't worry about it. Leave it like it is. Don't worry about it. However you get it on, leave it, because you will get the perfect time to work it. If one finger goes into 2 pockets, just leave it like that. Worry about this one, and once you're done with this one and you're both sterile, you can manipulate it however you want to. So with this, I know that, look at how it's on my hand, but I'm not worried about it because I can fix the problem here. Okay, and it's solely because also with my watch, but I can fix this problem. Now with this one, we are talking about this side being the inside. So this side, and it's both of I've not touched it, I've not done anything to it, so they are both sterile at this point. They are both sterile, so I can touch it whichever way I want to. They are both sterile. But this one, I will put my hand here. Okay, put my hand here like this, and this hand, which is not, it's clean but not sterile, I am going to put this hand in the hair like that, and patiently, and whatever happens to it, I'm not worried about it. But you try and put it, and you see my hand is still inside here. My hand is still in, so I'm still in the sterile field, and I can let go. Now that this is placed right, I can work on this. If this is bothering me, I can work on this. Now this is placed right. So if this is bothering me, the only thing I need to do is to put my hand here and work on this. And if I happen to have had one of these packets not be in, I can fix it. And now I have my sterile gloves on. And if it's like a total sterile, listen, I just push this away and I am clean. Hi, Janet. So that is how we put on sterile gloves. I hope it was useful to you. So if you're not a nurse and you come into a hospital and we're taking care of you, rest assured that we did it right. This is how you put on a sterile glove. Oh, Jana, thank you. Oh, Bright, Brighteria, thank you for showing up. That's my classmate. That's my schoolmate. The same year. So, see? We have this. And that is all you need to know with sterile glove. Now we've used it around, we've done whatever that we have to do. We've placed the Foley. I'll try and get a mannequin and one day we'll place a Foley. But we've placed the Foley, we've done everything that we have to do. We are going to take it off. Are we taking it off anyhow, anywho? No. So when we are taking it off, just like we take gloves off, we will take it off. This is how I take it off. I take a good portion of the glove here, and then I do this. So now I have folded it like that. And with this hand, with this finger, I go around it like this and inside out. So now I have what was inside now out, and this, I can safely dispose this off, knowing that I wasn't contaminated, or I didn't have whatever blood, whatever I had it. Janet, thank you so much. Whatever blood, whatever I have, this, it's in there. So please, thank you for joining me, and thank you for staying on. Please share when I post the stuff. Please share so that someone else will get interested. Talk to people about me. I do tutoring. I do mentoring, coaching. If you're a nurse in Ghana and you're interested in coming to the United States to be a nurse, general nurses. We have gotten to a point where midwives we are still considering, but a lot of these nursing board organizations are giving us a little bit of problem with our midwives. So I might get to a point where I'll stop doing help doing for midwives, kind of like getting them to come here as an NCLEX exams, writing their NCLEX, because most of these states that used to give midwives are now kind of like guarding themselves and not doing it. So please, 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 if you know someone who's interested in becoming RN in the United States, this is not an agency. We only consult and help you become a licensed nurse. If you are also someone who is interested in schooling in the United States, nursing, I don't know anything apart from nursing. If you ask me anything apart from nursing, I have to go and ask. I will have to go and ask. Yeah, right. Midwives were doing it as far back as 2000. Now they're giving us bad news. All the states that used to take midwives, they are not taking anymore. We have done a couple of them now that they've refused them. But we are still looking for BBR. There is some way, one way or the other, that we can look for the loopholes and get into it. But yeah, Bright, contact me. We are still looking for the loopholes to see what we can do about it. But midwives and general nurses, you guys are solid. We will help you. General nurses, you guys are very solid. We will help you if you are interested. My name is JustAbbyRN. I'm a nurse. I'm a nurse administrator, patient, and nurse educator. And also, I am a friend. You can always send me a message, anything nursing. Like I said, if it's not about nursing, I will try and ask for you. But nursing is all I know. Nursing is what I do. And so that is the best way I can help you. Aside nursing, I will not be of a lot of help to you unless I bring some people on board to help. But we are all here to teach. Oh, where's my teach? To teach and inspire. We are here to teach and inspire. So thank you for joining, and I'm very grateful that I have this group of people who kind of like supporting me every time. Mrs. General, if you're some tour, if I don't mention your name, don't be upset with me, but I know you all, right? I know you all. I see you all. I see the love that you showed to me, my family. I know my brother is somewhere, so let me give him a shout out. My brother, my big brother, and my friends, anyone who is supporting me. Thank you, and let's do this. Next week, we will meet again. I'll put forth the date and time that we will meet, but next week we'll meet again, and we will learn about something new and something that we can take with us as nurses, as patients, as loved ones, and my friends and some group of friends, myself and some group of friends, we are trying to come together and do some CPR education in Ghana, where we come, and that is the best way we can help someone. So we can help our country by coming back home to do CPR education and just teaching people that if someone passes out in the market, you don't need to run away from it or stand there and take a picture. You can get on there and resuscitate. There are a lot of people who are dying, who have passed because they did not get first aid. And so I have a few friends that we are going to come together and do this. We are going to come together and come back home and help and engage ourselves in the communities so that we can all help for Ghana to get a better system, better healthcare, and to help us all. So please, yes, Jesus, if you're interested, I'm a tutor. I do tutoring for NCLEX as well. So we can talk about it. Email me, NCLEXinfo@JustAbbyRN. NCLEXinfo@JustAbbyRN. So loved ones, thank you so much. I appreciate it. Nothing goes like I'm very appreciative of what you guys do, support me and encourage me. I'm not stopping. So I need your support and encouragement because me, I won't stop. If it's one person who shows up to this live, we will do it to the masses. We will do it like we're doing for 100 people. But support me and let's do this and let's help the people that need help. People like African people who want to be nurses. Let's encourage them because when someone sees that I am being successful at it, it will encourage another person. So please, please, please support me, support my life. Even if you don't want to watch, even if I'm annoying to you, just put the camera on and go and do something else. And let it just say that I have 15 million people watching me. I'm just kidding. But it's good information. We need to know this so that when you have a family member who goes to the hospital and something is happening, you can say that, oh, JustAbbyRN says that you need to stop drinking because that will hurt your liver. JustAbbyRN said that type 1 diabetics, you don't have to be a kid to be diagnosed with it. Something can happen to your pancreas and you become a diabetic. JustAbbyRN said that when you're giving yourself insulin, you shouldn't keep poking at the same spot. You should rotate sides and it should be 2 inches outside of your umbilicus. That is how we are learning and that is how I learn. That is why I love to teach. I love to teach and inspire. This is kind of like me, teach and inspire. You'll see a picture very soon. But thank you for joining and I really, really appreciate and love you all for being part of it. It's on YouTube. Share the link. Send someone to go to YouTube. And whilst you're there, please, 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 please subscribe. Turn on your notifications and let's have fun together. I love you all. Bye.